Hospital. I'm just going to ask the prof here on the right-hand side. I'm just wondering, a few days ago we had a case of a patient arrested on table in theater, a young trauma case. Fortunately for the patient, I was not involved in the resuscitation, but the resuscitation went on for 45 minutes and the patient recovered completely after 45 minutes with no RUSC. I'm just wondering, do you have a time limit of actually continuing resuscitation? I'm saying fortunately because I'm kind of 30 minutes used to be the cutoff line for me. I'm just wondering for how long should we continue resuscitating a patient?
Yes, I think that's a very important question. Now, from your description, that was a witness arrest because it occurred in the OR. So you have a big advantage that you initiate CPR without a no-flow state. I think the duration will depend on a couple of things. One is evidence that there is organ viability. For example, in other settings, I will continue to do effort if the heart is fibrillating, because a heart that is fibrillating is a heart that has a chance of recovering cardiac activity. Now, if there is a persistent asystole for more than 20, 30 minutes, and the CPR is ineffective, for example, by documented that your end-tidal CO2 is low, less than 10 millimeters of mercury, and if you have ultrasound and the heart is not moving, and you don't have any other options, you don't have ECMO, for example, available, I think at that point it's reasonable to stop the CPR and pronounce the patient. But if you have other capabilities and there's evidence of viability, I don't believe there is time. Let me give you a very brief example. I treated a patient about a year ago, young lady, 17 years old, massive pulmonary embolism, practically in cardiac arrest. I think it was a very severe shock, but she was unresponsive. We couldn't detect the pulse. We had her on a Lucas device for more than an hour. In the meantime, we figure out that that was pulmonary embolism, severe, massive. We give a bolus of thrombolytic agent, and she recovered fully. So knowing what is the etiology and having a plan to move forward, I think enables you to continue attempting resuscitation.
This patient for half an hour really, he was asystole for half an hour. And there was no circulation, and the end-tidal CO2 was low, and then he started VFib, and he was shocked a few times, and then he recovered after 15 minutes. So I'm just wondering, if I was involved in that resuscitation, as you said, probably after half an hour with low CO2, asystole, probably I would have terminated the resuscitation for this guy. But this guy now is completely recovered. I don't have...
How long was the patient in asystole?
Half an hour.
Half an hour.
I wasn't there. That's the information I got myself. It's bothering me because, as I said, if I was involved in that case, probably half an hour would be the cutoff line for me.
Do you know what was the temperature? Because there are mitigating factors. If there was hypothermia, for example.
It was not an active hypothermia. It probably was hypothermic, I would suspect, but there was no active hypothermic measures for this patient.
She's gone.
I just want to add something to that. I'm not in that situation very frequently, but I think it's a very difficult decision when you've been resuscitating a patient for a long period of time. Regardless of how well you know the patient, there becomes some emotional investment in it, and I think it's difficult to be the person that says, I think we should stop. And certainly in the UK, it's always a team decision. The hardest thing is somebody has to start that discussion, do you think we should think about stopping? But it always comes down to being a team decision. And I think increasingly, when I'm placed in that situation, I try to make sure I've got somebody else of a similar level of seniority there, just to confirm that they agree. But it's always a team decision ultimately. But I agree, I think it's incredibly difficult.
Any more questions, please?
Can I just add, it depends also on the age of the patient, comorbidities, why this patient had a witness arrest. Was it because of massive bleeding? So it is at induction. That was the cause, probably severe hypotension, the drug reactions or something. So we have to think why this patient arrested. and do as much as possible and maximize the time since he is a young patient.
I completely agree. I think just because we can doesn't mean we should. And sometimes our skills, increasingly our skills are going beyond our ethical understanding and knowledge. And sometimes we do things, and then it's only afterwards we think and reflect upon it. But I completely agree. It's the context of the whole situation.
I think that being in the hospital and in an environment in which the event occurred in relation to a procedure is totally different from dealing with a patient that suffers sudden cardiac arrest at home. And you might have a hypothesis, why is it that the patient went into cardiac arrest, and it was pharmacologically related to severe hypotension, then I think you have something to work with. Perhaps there's a way of reversing the hypotension. I mean, that's not something that happens commonly in the usual setting of a sudden cardiac arrest, that the mechanism is severe hypotension. Usually it's a cardiac event. So in that particular case, I will be encouraged to continue finding ways of providing what is critical, which is adequate myocardial blood flow. Now you have another option, which is to escalate in terms of the technique. If you're in the OR, maybe it's reasonable at some point to open the chest and do something that we forgot, which is open chest, direct cardiac compression. So I will be very creative in that. And I will echo the idea of when to terminate. Sometimes you need somebody else. Or ask the question. We have just instituted something, we call it the time out in ICU. Sometimes we are so focused on one aspect that we might ignore something very important, and somebody else who is next door can say, wait a minute, did you notice that you don't have the EKG connected in, it's not assisted, whatever. So it's good sometimes to bring other people to the scene in those situations in which you have somebody who was alive the moment in which you start the procedure, and brainstorm, not just the H and T's, but beyond that.
I just want to make one comment. If you want to read a really fantastic story about resuscitation, you may know it. It's the story, if you put into Google Swedish doctor, lake resuscitation, for something like that, it's the story of a Swedish orthopedic surgeon, a female orthopedic surgeon. She was skiing, she fell into a lake, she was hypothermic, she suffered a cardiac arrest, and she had a several hours downtime. But she was freezing cold. They worked so hard because it was one of their colleagues. They got her back, and initially she had no motor function at all. And she said, "I wish you'd let me die. I don't want to live like this." But she got everything recovered apart from her fine motor function. So she did have to switch careers to be a radiologist, but I don't think that's so bad. Anyway, it's a fantastic story to read if you could put it into Google.
I think we just raised a very nice subject, and Prof would like to comment.
I think I'm not really adding anything except to put it in the sense that when we are managing these cases, sometimes we get into the heat of the moment, and we forget, as the lady quite nicely said, what about the history? What about everything else? Have we figured out everything else? I presented a case in the intraoperative monitoring yesterday where at induction, not yesterday, the day before yesterday, the patient had hokum, and the anesthesiologist chose to give ephedrine. And with the hypotension and the ephedrine, the blood pressure actually got worse. And then the anesthesiologist started giving epinephrine. Well, the wheels really started to come off. And at that point, an echo was inserted, and it was a very clear, great big lump. I showed you the echo 2 days ago. A great big lump of a hokum, and with a systolic anterior motion SAM. So sometimes we can figure out, sometimes not. But when this is almost like the oral exam. When you're faced with a really complex situation, go back to the basics. What is the history? What are the physical findings? Is there something else I can figure out? The echo really helps if it is in experienced hands. I don't believe in somebody taking a weekend course coming in and say, oh yeah, I know what's going on with the echo. And then if after all of that nothing helps, there's no hypothermia, nothing else, then we are not God. And that's where the team decision comes in. So it really is a context of a sequence of steps. It's not just after half an hour do I just stop. Before you stop, have we done all the right steps?
Thank you everybody for the nice attendance of this evening, and thank you to all our speakers. I think Dr. Ali is leaving us, so...
Actually, to the issue of shocking rhythm, shockable rhythm, Professor Gazmuri nicely illustrated in one slide. And also, we learn a lot from our device patient. When they get into VF and then they get detected by the device and they get shocked, you see that the most successful shock is when administered very early. And a lot of time the patient maybe go into VF or in the ICU or in the emergency room, but they recognize it late. And it's a matter of seconds, up to 3 minutes, as the slide showed earlier. And in our devices, we usually program our devices up to 6, some companies up to 8 consecutive shock after recognition of the. If you are not successful in the first or second or maybe the third shock, then unlikely you're going to be successful in your fourth or fifth or sixth shock. So I think time is very important. And then there is a problem in defining unsuccessful shock, because that's very important. Successful shock means you get out the patient to sinus rhythm even for 1 beat. So that's successful. But the problem, if the VF comes back again, then your task is how to suppress the ventricular fibrillation. And in your case, maybe there is a trigger for the ventricular fibrillation, being ischemia, being a fixed aortic stenosis with hypotension. So you have to know why the patient into VF. I think time is the most important when you resuscitate a ventricular fibrillation patient. And that's, we don't need to, because once you get into drug, epinephrine, vasopressin, I think, khalas, you are getting basically into a cascade losing game.